Dr. Mustafa, how's the audio?
हाँ जी
ऑडियो ठीक है क्या?
हाँ जी आपकी साइड पे ठीक है ऑडियो
जी बिल्कुल ठीक है.
गुड
Sir, we are online. So
ठीक है can you see my screen
yes, we can.
Can you see us? Tariq Mustafa.
yes I can वालेकुम सलाम साद भाई
So, are we going to use the slides that we have, or are you going to go on the slides with him? Yeah.
Dr. Mustafa, we cannot see your screen. We can only see you.
So screen of slides यहाँ लगा दें.
give me one second
हमारे पास वैसे वो slides हैं ना. शरिया. मैंने आपको भेजी है. उनकी copy.
आपने एक मुझे भेजी है वो ये है.
Mustafa, we have your EUS principles and knowledge.
ठीक है we can go with that somebody will have to move
Yeah, we'll keep moving the slides. Don't worry.
ठीक है अगर if there is a way to share the desktop I could do that but मुझे नजर नहीं आ रहा
Oh, this is okay.
okay
We can see you, and so you can. Can you? We've got the first slide.
I just don't see my slides up though अगर if there's a way for me to see the slides then I can
Do you have your slides on your laptop?
I do
So if you can get them on your laptop,
mm-hmm
we have the slides here with us.
Now can you see
ठीक
our
है
screen?
yes now I can see your screen so that way I can be sure that we're on the
So
same
if-
slides
So if you start sharing your screen, we can see your screen then.
yes sorry for my ignorance but how oh it's a share screen
Yeah.
ठीक है now I think then you'll be able to see my slides right
Yeah. Yeah, we can see your screen now.
ठीक है and let me just go to full screen
Okay, great.
so now we'll go off my slides right
Mustafa, before you start,
Yeah.
let me just. We've got. I think what we'll do is we've done the basics of EUS. Khalid has covered quite a lot of
Good.
things already. So what we'll do is we'll do this EUS principles and knowledge. Okay, and Mustafa Arai, for those who don't know, is in San Francisco's University of California. He is the director of Advanced Endoscopy Fellowship, associate professor there, an excellent teacher. We are sadly missing him on this course. So I think for those who don't know Mustafa, we are missing a very good teacher here. Other than the fact that he's an excellent interventional endoscopist. Mustafa, over to you, please. Thank you.
thank you Saad bhai firstly thank you for inviting me yet again and I apologize for not being there I do miss this course, and I honestly look forward to this. This is one of the highlights for me throughout my year. With that said, I hope that inshallah in the near future I can be there. So I'll get started on this. Just to clarify, has Khalid Bhai already gone through these basics of ultrasound, or shall I go through this?
Just briefly, you can go ahead and do it.
Okay.
So you just go ahead and I think for it's a.
Yeah, Mustafa, whatever your presentation is, just keep going.
Yeah.
Repetition is always helpful, so just keep going through everything, whatever you got.
Yeah, you
Okay,
just
thank you.
stick to your presentation.
Okay, so we'll just start with some basics of ultrasound, which hopefully most people in the audience already are familiar with. But ultrasound essentially is generated by, or is defined as high frequency sound waves. So whereas the audible sound waves are in the 20 to 20,000 hertz range, when we talk about ultrasound, it's a much higher frequency of 2 million to 20 million, and that's why it's called megahertz. And that's where those waves are then used to generate a signal. So basically, an electrical current is applied to these small crystals called piezoelectric crystals that generate these sound waves. The waves are transmitted to the tissue of interest, and then the reflection from these waves is converted back into an electrical signal, and that is viewed as an ultrasound image. So some basic principles: any resistance to the waves will lead to the reflection of the waves to come back. If something offers no resistance, the waves will transmit through. And secondly, the best reflection is at 90 degrees. If you have any waves hitting an object at an angle, then there will be refraction instead of reflection. So the most crisp image is when the signal hits at 90 degrees and returns back at 90 degrees. Whereas if it's at an angle, we will get imaging artifacts, which are important to recognize, of course. So the other concept to understand is scatter.
Mustafa, can I just stop you there for a second? In case there is any question from here, you can interrupt and ask, okay? So please, I'm sure Mustafa doesn't mind that.
Of course not. Please feel free to ask.
Yeah, so you go ahead. Sorry to interrupt.
No problem at all. So the other concept to be familiar with is fraction. So scatter. So a small amount of energy that is transmitted will actually be either absorbed by the object or will bounce off the object and dissipate. Some will, of course, go through. Now, in a physiological setting, any structure will have a combination of different materials or different components. So whether that's liquid, solid, tissue, fat, and all these will have different characteristics when it comes to scatter. And a combination of those different scatters and reflections will lead to a specific ecotexture for the given object. So if, for instance, this is the liver, you have fat in there, and in a fatty liver, there'll be more reflection by the adipose tissue, whereas in a non-fatty liver, there'll be more reflection. So that will define the ecotexture of a given organ, as well as within an organ, different changes that can be seen. So in terms of how the ultrasound waves are displayed, if they're displayed as a waveform, that's called an A mode. The B mode is actually converting the ultrasound waveform into an actual image. And the B in there stands for brightness. So the cumulative results as displayed in the form of the B mode are what form the image of the object being evaluated. So if a transducer was to be passing in this direction from left to right over different areas, if we had just the A mode, we would just see scatter in terms of waves. With that conversion of those waves into the actual image is the B mode, which allows the wave to be converted into a image. And the brightness of that can be adjusted, and that is known as the gain of the B mode to make the image brighter or duller based on what the appearance is as we see it. So in terms of the brightness, as the signal passes through an object, the further it travels deeper, the less penetration there is, and there's more attenuation. The lack of penetration means attenuation or signal loss. And that's where the gain can be adjusted, even if you, for instance, feel like if you look at the screen with the red box, the closer it is to the probe, the higher it is on the panel. So the dials at the top are closest to the panel, whereas the dials at the bottom are most distant. So if in the middle there seems to be some signal loss, there can be fine adjustment of the settings for brightness within a given image. And this is known as spatial time compensation or time gain compensation. Both terms are used interchangeably depending on which machine we use. Other important principles are axial resolution and vertical resolution. So axial resolution is the discrimination of two objects that are in the same plane. So for instance, if we look, this is the transducer, and we're looking, say, through the esophagus at lymph nodes. So the esophageal wall and a lymph node will be in the same plane. The ability of the ultrasound to differentiate between these two things. And the important factor here is the frequency of the wave. The lower the frequency, the less we are able to discriminate between two different structures. The higher the frequency, the better the discrimination. On the other hand, it's inversely proportional to the depth of evaluation. So the higher the frequency, you can imagine that they just are stronger waves, but they lose their energy quickly, so you can't go very deep. Whereas at a lower frequency, they're not as energetic and they can go deeper. And this table sort of summarizes it. Frequency of 5 megahertz, you can actually penetrate up to 8 centimeters, whereas at a frequency of 20 megahertz, you can only go up to, say, 2 to 3 centimeters. And this may be relevant for evaluation of structures that are within the luminal wall versus deeper structures. So if you have a submucosal lesion in the esophagus or the stomach, you may go to a higher frequency, 10 or 12.5, whereas if you're trying to get deeper, a lesion in a deep portion of the liver, then you may want to decrease your frequency to get deeper. Whereas for a submucosal lesion, you would stay at a high frequency. The 20 megahertz frequency is not on the scopes. That's usually a different mini probe that can be attached for direct evaluation. So that's the frequency. And the lateral resolution is simply if the two structures are side by side, the ability to distinguish them. You can think of it as being in focus versus out of focus. And this is a combination of factors related to the scope, the size of the wave, and the frequency. And this is something that's determined automatically by the scope. We don't really adjust for this. This is a built-in feature of the scopes when we use our echo endoscopes. Moving on to flow. So Doppler flow essentially is a feature of the ultrasound to evaluate for flow in a structure, like a blood vessel. So a moving object will transmit signal at a different frequency than the signal is being transmitted by the transducer. And here, the angle at which actually, if it's 90 degrees, we may not be able to differentiate flow because it's coming right back up. Whereas if we're at an angle, then the movement is easier to see. So flow will be seen better at an angle as opposed to at 90 degrees. And sometimes one can think that you're looking at a cystic lesion and you put Doppler flow on, and you may identify that as being a blood vessel. So it's always important to look at anechoic lesions and put Doppler flow to ensure you're not looking at a blood vessel. And then there are different types of flow, whether it's continuous flow, pulse flow, which is a combination of the waveform, i.e. an artery vein, as well as sound. And that's a sort of pulse wave plus B mode, and that's called duplex scanning. Color flow, which tells you the difference in terms of the flow towards you and away from you. Red implies towards the probe, blue implies away from the probe. And power flow will be more sensitive than the conventional flow settings. These become more technical in practical day-to-day use. The things that are important are pulse wave, because that can differentiate an artery from a vein, which may be important sometimes, and just generally the concept of using flow to differentiate a vessel from a anechoic structure. Of course, there are different machines on the market. The one that we'll be using in the course and that most people are perhaps using generally is the Olympus EUME2 machine, which is a relatively small unit that can go on the endoscopy cart and has a panel with a keyboard, as well as some other buttons and a dial for adjustment, and I'll go over these. Or you can have a freestanding console. These are, of course, a lot more expensive, may have more features, but as gastroenterologists, we tend not to use a lot of the features that are available to us. So here's the ME2 on the endoscopy cart that you'll be seeing in your course as well. So the basic keyboard one has to be familiar with. Of course, you have the alphabets and the numbers, and then you have these different sort of buttons and the tracker ball, as well as a touch screen in the right upper corner for the different features. The first one to be aware of is the button, which basically allows the ultrasound signal to be transmitted or stopped. So when the scope's attached and you're not seeing a signal, the first thing to do is to check is the freeze button on. Maybe that's why you're not getting a signal. And it's best to always check that outside the patient to make sure that you have a signal in a little sort of jar of water, and you can see that your ultrasound scope is functional. Then you have these buttons for the depth/range. This is essentially a feature of zooming in and zooming out. So the plus sign will allow you to zoom into an object, and it'll tell you by how much you've done that. And on the left side is the minus, where you will be able to zoom out to see how far or big of a view you're getting. And these will become more sort of second nature with practice and time. The gain we talked about is the brightness, the ultrasound signal, and the higher gain, the brighter the image. So if the image is very dull, one can increase the gain to make the image brighter. And then within that screen here, up here on the right upper quadrant, right upper corner, you can hit the image, and you will have that sort of graph where you can fine adjust the signal as well. Again, in the bigger console, it's easier to do because you have dials in front of you. Here you have to go through a couple of steps, but it's doable. You have the image contrast, which is the black and white difference, which can be adjusted if needed. Again, a feature to make the image clearer and more. So if you have as an example, this is ultrasound of the liver, and if it's too bright, we can turn down the gain, and we get a duller image. And at high frequency, we may not be getting, we may be seeing it too superficially, but with the adjustment of the AEG balanced view. And here, of course, you have some like this image can be optimized to this. So in terms of the frequency, as I mentioned, the linear and the radial scopes will go up to 12 megahertz. Submucosal lesions oftentimes will evaluate with these scopes using up to 12 megahertz. Standard, at least on the machine I have, is 7.5 megahertz. And if I want to increase my resolution, I may go up to 10. For higher frequency, 20 megahertz, would have to use a special mini probe. And that's usually for small submucosal lesions. For a radial scope, this is more applicable. You can split the image from a complete circumferential image to split upper half, lower half, and back, so you can cycle through these. And then moving on to the flow, there, on the main panel there is the flow button, and from there you'll get different types of settings for flow that one can use to get the type of flow you want. And here are the three different choices: color flow, high flow, and power flow. And then you have different settings for the probe. If there's elastography, you will have that option on the screen too. So again, color flow will just differentiate blood flow towards the probe, which would be red, away from the probe, which would be blue. Power flow actually will give you brightness of the signal based on the degree of flow. So high flow will be much brighter, whereas low flow will be duller. And then the high flow is a sort of a composite of these with less blooming, less brightness compared to the power flow. And again, it doesn't really matter which of these three one uses. The main point is to use this when trying to blood vessels to differentiate anechoic vascular versus non-vascular structures. Then within the Doppler, one can change the gain so that the signal strength to see if it's not very audible, it doesn't mean that there isn't flow. It may be that our flow, and if we increase the gain, we may be able to pick up that Doppler flow. So it's important when you don't have flow to make sure that you change the gain to ensure that there's it's not an issue with not being able to. And then you have the option, if you're about to FNA, to split the image so you have flow as well as no flow, so that you can see where your needle track. This is a radial, of course, but on a linear you can do that too. But most of the time we'll just make sure we don't have any vessels in the way, and then turn the flow off and go with our sampling. In terms of the waveform, if you hit the power flow button, then you can actually see the waveform and get the audio for that. And for that, you can also adjust the range for which the vessel in which you want to monitor the flow. Because if these bars are too wide, wider than the vessel, then you won't be within the...
Mustafa, we got a little cut off there. Mustafa. Thodi si aap,
Yes.
Yeah, we just got a little cut off here. So the important thing about this is that if you have a structure that you want to know whether they're vascular or non-vascular, you use the flow.
Exactly.
Pulse wave or pressure, pulse Doppler you're going to use when you want to differentiate between a venous and an arterial structure, which is generally speaking required much less. But the more important thing is obviously if you want to know whether it's pancreatic duct or bile duct or it's a vessel, and quite often you will think that this is a ductal structure, but it turns out to be a vascular. So that's number one. And number two, like Mustafa said, when you're doing an FNA, FNB, you're doing a therapeutic procedure, you want to ensure that you're not going through a vessel. So you can actually adjust yourself, your position in such a way that that vessel is out, and these are the two main functions that you get out of this. And I think this is what makes EUS very useful, when a lot of times, especially in our system where patients have CLDs and varices and all, this becomes very useful when you're doing FNA or FNB. Sorry, Mustafa.
No, you're absolutely right. Thank you for that. But those are the two main functions. And then you can make, the point is that if you don't have what you're looking for it may be an issue with the settings, and it's important to be familiar with those concepts of adjusting the volume and adjusting the setting to get the flow, audio volume as well as sample volume. Otherwise, things to know about picture-in-picture. If you're trying to capture the ultrasound image, the caliper to make measurements for lymph nodes and masses, etc. And then the faculty will be able to show you, but you hit this once, it starts a reference point, you measure, and you push it again, you put the set button, and that gives you the measurement. And then you can add some comments and label the images too. So that's a bit about the console itself. Just a bit about the scope, and Khalid Bhai mentioned some of these factors too. The types of scopes we have are the linear, the radial, and these are just alongside an upper endoscope, just to show you the difference. If you look at the scope tip, it's not superly concerning, but you see that past the tip, the scope actually widens. And if you compare this size to this size of the scope, you can see that there's a significant difference. So just remembering that the EUS scope is larger and bulkier. And the other important factor is the bending angle of these scopes. So you have a 9.8 millimeter diameter scope for the upper. The radial is 11.8, and the linear actually widens to almost about 14.5 millimeters at its widest. And then the second important factor is that the straight part of the tip, once the scope is flexed, is much longer on the EUS scopes. So you're using a scope which is looking at obliquely at 45 degrees, as Khalid mentioned earlier, and you're going through turns like the duodenal bulb. So just keeping in mind that you have a larger tip to navigate through the duodenal bulb and strictures. The other thing is the importance of knowing the difference between the different brands. The ultrasound probe on the Olympus scope is much smaller, and the scan area is a bit smaller too, whereas the Pentax scope has a much bigger tip, and at least on the current model in the US, this tip is somewhat sharp, as opposed to here it's rounded at the top. The Pentax currently available in the US is not rounded. I don't know if the newer models are available in Pakistan yet. So knowing the differences between the two brands, of course, each company will have the specifics about the bending angles, up, down, left, right, and the channel size as well. So a few things about the scope functionality. I'm going to transmit video, and I hope this works. Otherwise, we can switch over to the slides over there. But remembering that big wheel towards you is flexing, and there's quite a high degree of flexion, and big wheel away from you is extension. So just remembering that you have these features. So if you're in the stomach and you're getting a lot of air artifact, what you may need to do is just do a bit of big wheel towards you to get against the gastric wall. And that may allow you to see through the gastric wall and look at the structure of interest. The same goes for the small wheel. Once you're trying to, for instance, evaluate the gallbladder, you have the gallbladder in view, you only get one part of the gallbladder. But if you do small wheel left and right, you can actually, or any other structure, then you can actually evaluate more of that structure by using the small wheels left and right. And even sometimes for sampling, you may have to do that to find the lesion of interest. I'm sorry that these are all upside down. It's just the way they got embedded into the presentation. The other component to know is that the freedom of movement. If we are torquing too much outside the patient, then the movement will be limited. Whereas if we are straight outside the movement, outside the patient, then the scope moves fast. So in the first part of the video, which I'll just play again, limited torque, but a lot of free movement. Whereas in the second part, a lot of torque, but limited movement. So keeping the scope straight is a vital sort of step to ensure that the scope movement is more fluid. The other concept is the elevator, similar to the ERCP scope. The elevator is there to help guide us and direct us. And for sampling, this comes in handy to angle our needle, as well as for the fanning technique, which I'm sure Khalid Bhai will go over in more detail. And the other thing is that the big wheel can be used to complement the elevator function. You can lock it and then use the elevator to get the area of interest in view for sampling. And that's essentially it in terms of the basics of the functions on the scope as well as the console.
Thank you, Mustafa. Any questions?
Thank you, Mustafa. I didn't know you can do EUS upside down while standing on a head.
Yes, no, it's an issue with my PowerPoint. I'll try and I'll try and fix it, but it's I've tried it once or twice doing it upside down. It didn't turn out very well.
Oh. You are being missed very much here. So we miss.
Thank you. Likewise. I inshallah next time I will be there.
Thank you once again, Mustafa. We'll now proceed to a live case. Khalid, you've had enough tea. So, any questions? Okay, when I first saw, I don't know Riyaz ka kya tha, but when I first saw EUS ka ye jo, the panel, I said, oh my God, this is like bloody going to a cockpit. How do I learn so many things? But most of the things are really and not mostly applicable. They're very simple things. What you've been told, you need obviously flow, you need to be able to measure, so you have the caliper, which is standard in all systems. There are some panels in EUME2, this particular model that we use. You have the luxury model where you have elastography and all that stuff, which we have here, and in one system we don't. So you can see both consoles. Most of the time, the thing that is useful is gain. Obviously, that's important. Brightness is important, but most of the time you don't. Frequency mostly is 7.5. Very rarely would you have to change frequency. I assume you don't. I really don't. Typing is very simple. You can easily, the panel shows you different organs, so it's already, all you need to do is just click and it will come. So you take the cursor, you put that there, and add is the command you need to give, and you'll have different options there: lymph node, pancreas, whatever, vessel, portal vein. So you can just click that, and it's very simple to do that. More than often, it's not done unless there is something, you know, usually some people do it, a lot of people don't. So really that's in that whole panel, there are like 4 or 5 things that are important, which are very simple. So during this process, what I would encourage is when you're doing your EUS, you use the caliper so that's important, flow is important, and just get familiarized with the depth and a little bit of brightness if you do. Most of the time you really don't need that either. I mean, mostly it's either depth, you know, or it's flow and caliper, okay? I think a couple of things that I have learned, and Khalid probably is, looking at what they showed with the bending, very, very nicely shown by Mustafa. I initially, like we do with gastroscopy, you know, with the head down, I think that's a little difficult. So my patients are in a neutral position. I find that easier to intubate, okay? Because this is not bending as much. So if the patient is like that, you are really unlikely to be able to bend it. So I feel that's better. If you have slight difficulty in intubation, it's best to take the scope out, put a gastroscope C, because even slightly strictured thing will have difficulty putting through a 15 mm. Okay, so your threshold has to be low, but most of you, because you've done a lot of ERCPs and endoscopies, it's literally nothing different, except the size is a little bigger. We haven't touched one thing here, we do most of our case still under sedation. Only patients that I don't do under sedation are the ones who cannot tolerate it. We tried with sedation and they don't tolerate it at all, or we are doing therapeutic procedures. Therapeutic, when I say it's biliary, or celiac plexus block or something. FNA and FNB, we just do it under sedation. And it's amazing once the scope is down how easily patient tolerates this. And that's something that I have noticed. It's much better than other procedures that we do. Why, I don't know. I have no explanation. Khalid, sorry, just before I come